Okay, this is part two of the endocrine. On this part, we'll talk about two other endocrine related issues, hypo and hyperpituitarism. We'll also cover chronic illnesses and children who deal with those, and we'll look at end of life care. The first thing we want to talk about is hyperpituitarism. It's also called precocious puberty, and that's what we're going to call it. It is early sexual maturation with development of the gonads, secretion of sex hormones. They have secondary sex characteristics, mature sperm and ova, and this occurs prior to the age of 9 in boys and 8 in girls. Um, the females will have breast development as early as 6 months or 3 years. Some babies are even born with pubic hair or develop it very early on. The thing is, they'll have a big growth spurt before their peers do. They will seem to be taller than everyone else, uh, but then later on in life, when everybody else has a growth spurt, they don't have one. So eventually, there's some catch up. Uh, they begin their periods earlier. They have the boys will have that underarm odor that's so bad in little boys a lot earlier. The thing the parents need to realize is that these kids can reproduce. They are fertile if they have precocious puberty. They have that accelerated growth, and then they have the epiphyseal fusion, so that's what causes them not to have that second growth spurt, so that they end up not being as tall as everybody else. Treatment is Lupron injections once a month, and what that does is kind of puts a pause uh, on the growth. And then once the child hits the age of their physical appearance and their sexual maturation, they can withdraw the Lupron, stop it, and the child will continue to grow from there. A lot of the time, the treatment is going to be based on what's causing it too, if there's some underlying cause. Nursing, the thing we need to really realize is to teach the importance of compliance with the medication. You need to teach the parents and discuss with them the importance of dressing the child age appropriately, not necessarily their physical appearance appropriately. Be aware the child is fertile. They may need to start them on birth control if the child is suspected of being sexually active. This is the 10-year-old that you'll find a 17, 18-year-old hitting on because she looks like she's 16. So you have to really talk to the girls about it, and even the boys, because the older girls will be hitting on them. Um, it's a really good risk factor, a big risk factor for pedophile. So we really need to have a conversation with the kids about their physical appearance and how that could um, distract someone of the older age to assume that they are of age of consent. On the other end of the spectrum is hypopituitarism. We also call this growth hormone deficiency. The baby may seem normal at birth, be right on the growth curve, and then with each appointment for checks, well child checks, they start to fall off that normal growth curve. The primary site of a dysfunction seems to be the hypothalamus. There are multiple causes though. Um, Diagnosis requires a good history, and be sure and look at the parents. If your parents are only 4'11", both of them, don't expect the child to be 6'2". So you want to look at the parents before you make a diagnosis of growth hormone deficiency. Um, Look at their nutritional history. They'll do a bone age to see what their bones look like. Look at the growth pattern. Look at your line on the growth chart. Have they stayed on a steady 20% below normal percentile, or did they start out at 50% and then they went to 30% and now they're down at 10%? That shows they're falling off. What they'll do is they'll bring them in. They'll be NPO for 10 to 12 hours. Um, they may do what's called growth hormone stimulating test. They give the child a dose of levodopa. They'll put a patch or a 4x4, some kind of dressing on their arm. They will send them away from the hospital and tell them to be active, eat, play, do whatever they normally do, and then they'll come back and they'll draw blood and see if what the levels are. If the level is less than 10, then they're diagnosed definitely as growth hormone deficient. So what do we do if they test positive? Treatment again depends on if there's an underlying cause. If there's an underlying cause, they're going to treat the cause. If it's just a deficiency in the growth hormone, then they'll do growth hormone replacement. It is an injection given sub-Q, and it's given at night because that's when your normal growth hormone releases from the body. They will check other hormone levels. If they're deficient in any other hormones, they will try to replace those as well. They really have to keep an eye on the kid's blood pressure because growth hormone can cause a spike in blood pressure. Prognosis, 80% success rate. It's more effective when they start it younger, or those kids who are severely deficient. They can reach near normal height, but sometimes what stops the treatment is the cost. It's about $30,000 and up a year for growth hormone. Nursing care, again, a good history and assessment, and we need to educate the parents that even though the child may look like they're 8 or 9 years old and they're 15, they need to dress age appropriately, just as the opposite with the hyperpituitarism. They need to dress as their age, and they need to be treated according to their chronological age and not the way their body size is or the way they look. So we need to talk to them when they come to the office and visit the nurse. We need to make sure that we address them, if they're a teenager, as if they are responsible for their care, not like you would an 8-year-old where you would address the parents. Okay. The next section we're going to cover is we're going to talk a little bit about chronic care, kids with chronic illnesses, legal responsibilities, what the schools need to provide, what we should expect, and how kids should be treated that have chronic illnesses and what that means. First, what defines a chronic illness? Well, a chronic illness is any condition that interferes with daily functioning for more than 3 months a year, or it causes hospitalization of more than 1 month a year or 1 month at a time at diagnosis. So we know cystic fibrosis, those kids come in usually every 6 months for 2 weeks. So that's 4 weeks a year, plus their other admissions when they need admissions, if they get sick, and it does interfere with their daily functioning. You really want to focus on the kids' developmental age, and that's how we need to approach their care. What can they understand? If it's an illness that they've had for a long time, then treat them like they know what they're doing. Don't go in there and try to tell them how to take care of themselves. Ask them what they know. Ask them what they've been doing. Let them have input, especially if this is something they've had all their life. This is something they've lived with forever. We really push that family-centered care. Remember, the family becomes the expert in how to take care of their child. Watch and learn how to give care to their kid See what works for them. See how they do it. If the kid has a GT button and that's how they get their medications, or the medication is ordered oral or PO, and they have a GT button, ask the parent, how does your child take their medication? Do they take it by mouth or do you put it in their tube? They may take, if they have 6 pills, they may have 3 that they take by mouth, and then they may have a nasty tasting vitamin they want you to crush up and put in their tube. They're the experts. We're going to do it the way they want it done. They know what works best for their kid, even though their way may not be the way you were taught. The family is the expert. Unless they're doing something that's going to harm their child, we need to listen to them. The family may have several concerns related to their child and illness. How will their child access education? How will they pay for needed services and supplies? The uncertain future. Who will take their child if something happens to them? Who's going to give that long care if there was to be an accident, or if the parents themselves were to get sick? They grieve the diagnosis and the child's lost opportunities. We talked about that in diabetes. Parents don't think throughout their whole pregnancy, oh, I wonder if my child will have X, Y, or Z. I wonder how that will affect them in the future. No, they make plans for that perfect baby that will someday be the best at anything they try to do. And so they are grieving what they see as missed opportunities for their child. Social isolation for the child and the parent. I mean, think about when you get to the hospital, you're going to see these kids with cystic fibrosis that are put in isolation at the hospital. They can't be within so many feet of another kid with CF. It makes them feel isolated. They used to have a CF camp. They still have diabetic camp, which is good. A lot of the different camps, Aldersgate in Little Rock has camps for a lot of kids with disabilities, kids with burns, so that the child can see that they're not the only one that's been affected. That makes it good because kids feel so isolated, and you know, as you studied growth and development, that interaction with peers becomes more important even as the child gets older. When the child comes to the hospital, we want to have normalization as much as possible. We want to establish a normal pattern of living that's not disruptive on the patient or the family, and that's going to help us promote that growth and development we've talked so much about promoting while the child's in the hospital. In years past, these kids with chronic illnesses either didn't return to school once they were diagnosed, or they were in special classrooms. Now that could be your Down syndrome kids, your kids with mental disabilities. Those kids, a lot of them were put in special classrooms. Now we focus more about mainstreaming. They may have a special classroom, but they are also integrated into the classroom with the normal, quote, kids. Children we once thought could never participate in educational activities because of their diagnosis now are flourishing and rising to the challenge of being in a traditional classroom at least part of the day, and are learning how to interact with kids that are different from them, as well as a time to interact with kids that are the same as them. So what gave them this opportunity? It was the Individuals with Disabilities Education Act of 1970. So what is the Individuals with Disabilities Act? Like I said, it was first done in 1975, and it required public schools to make available to all eligible children with any disabilities a free, appropriate public education in the least restrictive environment to meet their individual needs. I hope that you will look up the Individuals with Disabilities Education Act and answer these 3 questions on the right side of the slide. 4 things this program does, what is an IEP, and what disabilities are included. The IEP we'll talk just briefly about, but I want you to read more about that because I think it's very important that you understand, because not all of you will be school nurses, but some of you may one day be a school nurse, and you need to know what is your legal responsibility to a child with disabilities. It requires the school system to develop an appropriate, individualized education program, that's your IEP, for each child that has a chronic illness or disability. The specific special education and related services should be outlined in each IEP and reflect the individualized needs. So they're not alike, they are individualized. So, what one kid with Down syndrome may need, a kid with cystic fibrosis may need something entirely different based on their individualized education plan. But it's responsibility to the school to work with the parents to make sure that that plan is formed and then put into place. It is to be reviewed annually. The Individuals with Disability Act also mandates that particular procedures be followed in developing the IEP. It has to have a team input. It should be the teachers, the parents, the child. If the parents disagree with their child's IEP, they can request a hearing and review from the state to look at it. This can even mean a child that is suspected of having a learning disability that affects them. The parent can request an evaluation. So if they think their child may have dyslexia, they can ask the school to do testing and evaluate their child to see if maybe that's why they're having trouble learning. And it's the school's responsibility to do that. This can include mental or physical disabilities. It was updated in 2004, and it included the homeless as a disability. So what kind of accommodations are we talking about? They have to give them accommodations. So what are we talking about? And this goes even into college. The college is also under this Individuals with Disabilities Education Act. It could be highlighted textbooks. It may be audio books, a set of audio books for them to take with them. Extended test or assignment times. If you are a student listening to this and you have a reading disability that requires you to read things several times to understand, then if you have a documented disability, you can go up to the testing center. You can go over and request, or it may not be the testing center, but you can go over to the main office building and talk to the disability people over there, and they will get you extended time on our exams. That's something that we usually talk to students about if they come and they're struggling with the test, getting finished with the test. Peer assistance with note taking. Maybe you have trouble keeping up with the notes. They can have, they'll pay or supposed to pay someone to sit with you and take notes. Frequent feedback. Extra set of textbooks for home use. Maybe you're in a wheelchair or you don't walk very well and you can't, you're not good at carrying a book bag and you don't have anything on wheels. So you may petition to have a set of books at the school where you have a locker and a set at home that you leave so you can just take your assignments home. Computer aided instruction. Enlarged print books. Behavior intervention plans. Rearranging class schedules. Visual aids. Taping lectures. Not all schools allow you to tape their lectures, but with the Disabilities Act, if that's how you learn, then they have to provide that. Preferred seating. Maybe you can't see at the back of the room and you need a front row seat and it's always taken. Well, this can get you preferred seating. Oral testing. Individual contracts. These children will usually be in a regular classroom unless their behavior is disruptive to that class. And if they have disruptive behavior, then what they'll do is they'll try them in a couple of classes to see if maybe the shorter periods are better for their behavior. Parental rights. The parent should receive notice regarding the identification, evaluation, and placement of their child. They can have the right to examine all relevant records. They can request an impartial hearing, file a complaint with the school district, file a complaint with the Regional Office for Civil Rights, We've had a student who had to go to court because the school where her child should go would not provide the things he needed in order to be successful at the school or to be able to even attend the school. And so she went to court and got those things. When doing an IEP, the parents need to contact the school officials before the meeting, keep a record of all communication, be on time and have a plan, have an idea what they want to ask for. Read everything before they sign it. Insist that all key decisions are in writing. Don't just go on, well, he said that they would do this. Make sure it's in writing. Don't go in alone. You can always dismiss someone from the meeting. Take notes. Examine the goals for your child and be persistent. Remember, you're fighting for your kid. So that is the chronic care. With diabetes, they have the right to check their blood sugars, to keep treats at the school as needed for when they need them for low blood sugars. There are kids who are allergic to certain foods. They have the right to know when those kinds of foods are being served. So this covers a plethora of disabilities. So when you start doing a little research on it, you'll see some of the disabilities that are listed. Okay, the next subject is not always an easy one to talk about, especially with kids. It's not natural for a parent to lose a child. You always think of parents dying before the child does. What you need to do is go back and review from second semester, or first semester actually, your stages of grief and loss. Those Elizabeth Kubler-Ross. We know that accidents are the leading cause of death in children. So you're dealing with parents that usually are not prepared for the event. And so it's traumatic, just the fact that there was an accident, but then to have the child die after the accident. Someone has to be blamed. They may be blaming someone else, or they may feel guilty themselves if the accident happened on their watch. Even if a child has a terminal illness, you are never ready for your child to die. A lot of parents are, that's said to, but you've known they were going to die for a long, they've had this terminal illness. I'm sorry, but you're never ready. Even if you lose a parent that's 90 years old and they were ready to go, you're never prepared. You're never ready for that event to happen. It's such a final event, and that's we just always feel like there's something more we could do to prepare. Palliative care helps promote a graceful, natural death rather than attempting to prevent death. So you'll hear palliative care a lot. It's usually discussed with the family if the child's illness reaches a point where death could occur in the next 6 months. You'll also hear hospice. This care offers comfort and compassion to the patient and the family. It can be in the hospital, or it can be in the home. Infants and toddlers, they don't really understand death. They may respond to the grief of the caregivers. So if someone dies, you may see a toddler crying because they see their parents crying. Preschoolers believe that death is something that happens to someone else. It's not permanent. Look at your cartoons. I mean, you have somebody die in a cartoon, and the next thing you know, they're in the next cartoon. Or they jump up in that cartoon after they die. They are very curious about death. They want to know what this is all about. So they may ask repeatedly how someone died. They may be afraid of death. Miss York told some interesting stories, and I hope she will again, in one of her lectures of her son Preston when Matt's grandfather died, her husband's grandfather. They talked about him watching over from heaven, and Preston said, well, how can he don't have his eyes open or his eyes are closed, because that's how he saw him. was with his eyes closed. So that's the kind of preschool image they have of death. They don't really understand that. School age know that death is universal and it's final. It's something that will happen in the distant future when they're old, like their mom and dad. Now, mom and dad may only be 40 or 30, but that's old to a school age kid. They don't want to talk about it. You know, even if one of their classmates die, they may want to briefly mention it, but it's not something they want to dwell on. Adolescents understand death in a more logical way. They know it's permanent, but of course, you've had the growth and development. Death is not going to happen to them. They are invincible. If it is a friend that died, they need closure, whether it's going to the funeral or talking with the parents, being with other friends that knew this friend. They need that closure for it to be real. You need to know who is the person that's making the decisions and how it relates to the child's care. Hopefully by the time they get to this point, you've taken care of them enough. You know who is the one making all the decisions. It's not always the dad. Sometimes it's not even the parents. It may be a grandparent that has assumed care of the child that's making the decisions. Okay, taking care of the child. Don't underestimate the child's ability to understand what's going on. You need to have open communication with that child. Listen, what are they asking you? Give them honest information. One thing a child can do is they can always tell when you're lying to them. It's okay to tell them, I don't know. Answer only what they want to know. In my nursing career in pediatrics, I started out on the oncology unit where we saw a lot of our kids that did not do well and they died. Then I moved to the adolescent unit where I took care of kids that had cystic fibrosis, which is also another terminal illness. And I remember one of my 13-year-old CF girls look at me in the eye and saying, am I going to die? And it startled me because we weren't even having a conversation like that. And I looked at her and I thought, I can't lie to her. And I said, Anna, you know what your illness is. Says, you've seen some of your friends up here that died from your illness. We haven't got a cure, so eventually this illness can kill you. And I said, but the one thing I do know, it's not going to be today, and I doubt it will be tomorrow. And she was fine with that. I think she just wanted to know if I would be honest with her. So sometimes you have to know, what are they asking and why are they asking it at that time. Provide creative outlets to deal with the anger and the feelings. We had a chaplain one time who every time the CF kids would come in, he would take them downstairs to his office, and he had a little area set up, and he would video them and ask them questions. Simple questions, not in-depth theological questions, but simple questions like, tell me about your best friend. If you knew that you were never going to get to see your best friend again, what would you want to say to your best friend? And then when the child would die, he would take that video, put them all together, and give it to the parents. Wonderful gift for parents to have. It's something that would last forever, a visual and an audio of their child. So it was very creative. Allow time for the family and for the patient to say goodbye. Let them have alone time. Don't all the time be in their room. They need privacy. Permit the child to share their pain and grief. Ask them how they feel, and then stand there and listen to them. Don't be rushed out of the room. This is not the room you want to go to first, and know you still got to go see other patients. The child may choose to protect the parents by not sharing with them. So you need to encourage them to share with their parents. Assist the dying child to live as long as they can. Comfort measures. Special moments celebrated. Even if the kid can't get out of bed, if it's their birthday, celebrate. My same patient, Anna, for her 13th birthday, We decorated the playroom at Children's, and we wheeled her down there, bed and all, to celebrate her birthday. Surround them with people that mean the most to them. This is when you want to have that consistent nurse. You form bonds with these kids, even the adults, um, the families, and so you want to make sure you have those same caregivers as long as it's still comfortable for both of them. Maintain peer friendships. If they're a teenager, especially, you want to make sure they maintain that contact. Encourage their friends to visit. We had a 16-year-old that was diagnosed with cancer, and he had been on the football team at his high school. The cheerleaders came up one night and stood in the hallway and did cheers. The other patients didn't mind at all. It wasn't bedtime, but it was so important for him because he was in isolation. So he stood there at the window of his door and watched the cheerleaders cheering him on in his battle. For the parents, it's hard sometimes to deal with the parents. Allow them to participate in the care as much as possible. Whatever you're in the room doing with the child, if they want to do it, let them be the one to do it. Allow them to express their feelings as they feel comfortable. Encourage them to be patient with themselves. They want to fix it. That's their job as a parent, is to fix boo-boos, to make their child feel better, but this cannot be fixed. Talk about the child. Talk about happy memories. Share things that are positive with the parent. Say, I remember when they were in the hospital this one time and we did da 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 da. Bring back those happy memories. Even if it's in the hospital, it can still be a happy time. Educate the parents about the changes that are going to take place. What can they expect as death nears? It may be breathing changes. It may be color changes. It may be level of consciousness changes. But let them know what to expect. You may have to repeat these several times because they're having that selective hearing and they don't always take in what you're saying to them. The one thing we wanted to talk about is controlling pain. No parent wants to see their child hurt, so we're going to be very specific about controlling their child's pain. Let your genuine care and concern show. Be available to listen. Use statements like, I'm sad for you. I know this is hard for you. I'm sorry for the pain you're feeling right now. Is there anything I can do for you? Is there someone else you'd like for me to call? Don't ever say, I know how you feel, unless you literally have lost a child and you know how they feel. Then you can talk to them on a different level than what you can if you've never lost a child yourself. Don't offer the idea about, oh, well, you're young, you can have more kids. That's like saying, oh, well, you can replace this child with another one, because that doesn't happen. It doesn't matter how long they've had that child, you don't replace a child. For them, it will never get better in this moment. So don't give them that, oh, well, it'll get better, because they don't see that. So don't give them that false assurance. Encourage siblings. If the siblings are up there, you want the siblings to be involved. Give them privacy and allow the sibling to interact and to talk to their sibling before the time comes. Once death has occurred, what do we do then? Do we need to rush the family out? No. Let the family spend as much time with their loved one as they want to before you start going in and doing things to the child's body. Voice empathy by acknowledging their grief. If the family wishes to participate in that post-mortem care, allow them to do that. Allow any cultural or religious rituals that need to be done at the time of death. Let them take mementos. They may want to take some hair clippings. They may want to take one last picture. I know that seems morbid, but they may want to dress if it's a baby, they may want to dress the baby and take some pictures, last minute pictures. Remember, this is all they're going to have left to take with them when they go, because the child is gone. It's okay to cry with the family. especially if it's a child that you've cared for over an extended period of time or years, but don't let your grief overwhelm the family. Um, if you know when the funeral is going to be or a memorial service, attend or at least send a condolence card if this family um, connected with you or you connected with the family. It lets the family know that the child meant something and left an imprint on someone else's life besides theirs. The last story I want to tell, and I've told this every year since I've been teaching, since it happened. Uh, my little Anna that I took care of that had cystic fibrosis, when I knew that she was dying, I had to transfer off the floor. Couldn't take care of her anymore. It had gotten to the point where I was just too attached. So I had transferred over to the clinic area. And one day I got a call over there, and they said, if you want to see Anna, you probably want to come up today and see her because we don't think she'll last through the night. I said, okay. So I went over to the hospital to her floor, and her mom and dad were in there, and they said, we're going to run down to the cafeteria. And I said, okay. And so I went in, I sat down on the end of Anna's bed, and she was down to probably about 55, 60 pounds. And I took her little hands, and I said, hey, Anna, how are you doing today? And she looked at me with those big brown eyes, and she said, I'm sorry. And I said, what you sorry for, babe? She said, for dying. And I said, oh, Anna, don't be sorry. I said, you fought so long and so hard. And I said, you're going to beat this cystic fibrosis. I said, because when you're gone, it's gone too. And I said, you don't have to apologize to me for being a fighter. And I said, I've watched you fight and you've done well. So then we started talking about something else. And her mom and dad came back up, and I got ready to leave the room. Her mom walked out of the room with me, and I told her, I said, you need to go in there and tell her it's okay. I said, she's in there holding on because she's afraid she's disappointing everybody if she dies. And I said, so you need to tell her it's okay to let go. I said, she's fighting so hard just to hang in there. And her mom and I shed some tears together, and I hugged her, and I left. And about 2 hours later, I got the call that Anna was gone. And I went back over there, and I talked to her mom and dad, and I hugged her mom, and I said, I don't know how you're standing. I said, because I know how hard and how bad my heart hurts. And I said, she wasn't my daughter. I said, I can't even begin to imagine the pain that you're feeling right now. And we stood there and shared some memories of Anna and her birthday party and some of the funny things she would say. And then they left the hospital. And I went to her memorial service. It was in Lilly, Louisiana. It was in Lilly, sorry, it's my dog barking. It was in Lilly, Louisiana, and drove down there for her memorial service. And it was the most beautiful thing that I ever been to, and it was closure. That was in, I believe, September. And in December, we were having the memorial service at Children's they have, where they put a Christmas tree up and let families come back and put ornaments on the tree and honor in memory of their child that they lost during that past year. And Anna's parents came. And Anna knew I collected clowns. And so she had bought a clown for me for a Christmas present to give me that year at Christmas before she passed away. And her parents brought the clown to me that day, and I still have that clown as a memory of that sweet little girl that I took care of for more than 8 years. So end-of-life care is so vital. It's almost as important as that beginning of life care, because you're there when the patients and the families are the most vulnerable at both ends of life. So my hope and prayer for each of you as students is that you will be able to give that kind of compassionate care whenever you're taking care of someone as they get ready to cross that threshold from life to death. It's not easy, but it's something that we nurses have the honor to do as patient caregivers. And that's the end of our lecture.